Good afternoon, everyone. My name is Sarvee Moosavi. I'm a gastroenterologist at Vancouver General Hospital. I've had extra training in neurogastroenterology and GI motility disorders, and I'm now doing my Master of Education. So hopefully I'll be done in 2025. The focus of my talk this afternoon is to give you an overview on diagnosis and management of irritable bowel syndrome. If I could advance my slide, perfect. So the objective of my talk is to define these disorders of now called gut-brain interaction, which were formerly known as functional GI disorders. I'll talk a little bit about epidemiology and implication of these disorders of gut-brain interaction. And I'll discuss as much as we know about the causes of DGBI. That's what I'm going to refer to them throughout my talk. And then I'll talk a little bit about the sort of clinical pictures of irritable bowel syndrome and spend the good chunk of this talk on management plan. So the overall classifications of disorders of gut-brain interaction is really characterized by these chronic GI symptoms in the absence of, for now, demonstrable pathology on conventional testing. So there's really no good biomarkers for a lot of these diseases. And it is partly due to alterations in the brain and gut communication. And I'll come back to that later in my slides. And the current classification is based on what we call Rome criteria. So this is essentially a group of experts that they come together, they define these disorders based on certain criteria. And currently there are 33 disorders of gut-brain interaction in the adult population and 20 in pediatric or kids population. The most common subtypes include irritable bowel syndrome or IBS, chronic idiopathic constipation or CIC, and for now we have functional dyspepsia, but unfortunately functional dyspepsia is out of the scope of this talk. I just don't have enough time to also include that in the talk today. So I'm going to focus mostly on IBS-C and touch upon CIC as well, but generally these disorders present with abdominal pain, bloating, altered bowel habit, early satiety, sometimes even nausea, and postprandial fullness. So on the right-hand side of the screen, you see basically a whole list of these disorders that are divided by anatomical distribution, esophageal disorders, gastroduodenal disorders, and of course the bowel disorders. And we also have centrally mediated disorders, particularly with centrally mediated abdominal pain, and I'll touch upon that as well. So let's start with looking at epidemiology, just what percentage of the global population suffers from these functional GI disorders or disorders of gut-brain interaction. This was a study that was published 3 years ago, and back then more than 40% of people worldwide are affected with these disorders. And Canada is amongst the countries that actually has higher prevalence of these disorders. And when you look at any of these disorders of gut-brain interaction, it can affect close to 42% of the population. Functional dyspepsia affects around 8%, IBS affects around 10%, and chronic constipation affects around 10% of population. And functional bloating, meaning just you have abdominal bloating, you don't really meet the criteria for constipation, dyspepsia, or CIC, and so on, that affects around 3.5% of population. It's when you look at these patient population, you actually see that a lot of the patients unfortunately suffer from more than one disorder of gut-brain interaction. So those circles are demonstrated basically based on anatomical distribution. So we have the bowel disorders, gastroduodenal disorders, anorectal disorders, and esophageal disorder. And you can see that these circles overlap with each other, so that, for example, a patient who suffers from IBS may also have symptoms that actually meet the criteria for functional dyspepsia. Our life changed due to COVID, and it continues to leave its impact throughout our lives. So about 700 million people were affected by COVID worldwide, and we now also see increased incidence of both IBS and functional dyspepsia in patients who had COVID infection at one point in the past 3 to 4 years. And the reason being is that, as you can, is that, COVID can contribute to these long COVID symptoms, and we don't quite know exactly why some people develop these long COVID symptoms while others don't. But COVID can actually live in our gut. And whether that sort of low residual active infection that remains behind, or whether it's the effect on the microbiome, or the integrity of the lining of the gut that it gets perturbed by this SARS-CoV-2 infection that we had, it can result to development of these disorders of gut-brain interaction. IBS affects productivity amongst all age group that are affected, but most importantly, people who are in their early adulthood, between 20 to 35 years of age, are the ones who are affected by this disorders, and it tends to peak at about 35, 40 of age, and then it kind of dives down a little bit. But these are the patients who are going to school, who have family, who are working, who, trying to actually have a very active life. And unfortunately, they get affected by IBS. So it can really impact productivity of patients during those critical years. While the incidence of other diseases, the prevalence of other diseases are actually lower in that age population. And of course, it grows higher as we grow older with cancer, heart disease, and arthritis, and so on. IBS tends to die down a little bit. And you can see on the right-hand side, it shows you the percentage of the population that are actually permanently unable to work. And yes, arthritis, cancer, diabetes, and heart disease are there, but you can actually see that IBS is not far behind these disorders. And it's one of those disorders that unfortunately is really under-recognized, under-treated. Probably not enough resources go into actually treating the patients because it does require a multidisciplinary approach. But unfortunately, we do see the impact of it, both direct and indirect cost to our socioeconomic effect. So breakdown of the cost here is just showing you essentially the big piece of pie, essentially the amount of resources that go into diagnostic tests. Unfortunately, many patients with irritable bowel syndrome have multiple colonoscopies, multiple upper endoscopies, multiple CT scans, tons of blood work, and yet they feel like they don't actually have the answer or a definite diagnosis, which makes it really complicated because they just feel completely hopeless. Also, the primary care facility, the emergency visit, the prescription medications that don't work, it's just a complete utter frustration for both the patients and of course the clinicians as well, because they feel like they're not really helping their patients. In Canada, patients with IBS misses about 13 work days per year, and it's probably higher because this is actually an older survey that was published, and that accounts for about $8 billion of loss of productivity each year. And the annual economic healthcare burden of IBS exceeds almost $7 billion in over-the-counter medication and prescription medication. This was a neat survey that was done. The question was that what would you be willing to give up for 1 month of IBS-C symptom relief? About 20% of the patients said I would give up internet, cell phone, caffeine, alcohol, sex, and so on. And it was an international survey of 2,000 adult patients were diagnosed with IBS, and patients reported that they're willing to give up 15 years of their life, 15 years of their life to receive a treatment that would make them symptom-free. So that tells you about the burden and impact of symptoms on the patients and basically the clinicians that really need to feel confident to make a positive diagnosis so the patients can actually move on to treatment option. So I've showed you all of this to say basically IBS is quite frustrating for patients. Particularly, it takes a long time for a lot of patients to obtain a diagnosis. And a lot of patients, like 50% of the patients, have suffered more than 10 years before they get a firm diagnosis of irritable bowel syndrome. Symptoms can be quite incapacitating. And of course, we'll talk about the treatment burden as well. And we don't really have any good biomarkers for it. There's no blood test, there's no imaging, there's no feature specifically on colonoscopy or upper endoscopy that's going to point to the diagnosis of irritable bowel syndrome. And the sooner the patients are actually given the diagnosis of IBS, the faster they can move on to the treatment options. And I'm going to tell you more about the treatment paradigm. But before then, what is IBS? Like, what's the definition of IBS? So currently we have Rome 4 criteria. So every few years, Rome group sit together. They basically look at the criteria, look at the evidence, look at the study and the literature that we have, and they see whether or not we need to modify any of these diagnostic criteria. As of right now, IBS is defined as a disease that has recurrent abdominal pain on average at least 1 day a week in the last 3 months, associated with 2 or more of the following. So the abdominal pain is associated with defecation. It's no longer that it requires to improve with bowel movements. That was a previous definition of IBS. When we now know from the studies that, in fact, some of the patients actually have worsening abdominal pain after defecation or bowel movements. And it's also associated with change in the frequency of the stool and also the appearance of the stool. So this slide, I find it is a little bit easier to kind of visualize it, and it really divides the IBS into various subtypes. The most common subtypes that we encounter are the IBS-C, or the IBS-C stands for IBS constipation, IBS diarrhea, IBS mixed type. Very few patients would fall into this sort of realm of IBS undifferentiated. And it's really divided by the bowel movement consistency and form. If you were not to use any anti-diarrheal medication or laxative, what is the main type of stool that you have? If 25% or more of the time it's hard, lumpy stool, you have IBS-C. If it's 25% or more of the time you have diarrhea, without use of any, again, laxatives or anti-diarrhea medication, it's not really altering your baseline bowel movements, then you have IBS diarrhea. And if you have somewhere in between, you have IBS mixed type. I mentioned that I'm going to touch upon the CIC, or the chronic idiopathic constipation. Again, it's not necessarily black and white. It's not like you either have chronic idiopathic constipation or you have IBS constipation. I find the majority of the patients actually fall somewhere in between. So the difference between chronic idiopathic constipation versus IBS constipation is that the patients who have CIC generally do not report as much abdominal pain. Although if someone has severe CIC that they're not necessarily having any bowel movements for 2 or 3 weeks at a time, of course you're going to have so much stool in you that you get the colonic distension from all the amount of stool sitting in there, and of course that stretch in the colon, that's what generates pain. And that, patients can have abdominal pain, but it's not one of the main cardinal symptoms. Whereas the patients who suffer more from IBS-C tend to have more abdominal pain. But a lot of patients fall somewhere in between in this sort of, paradigm. And the management option for these two are more or less similar, with maybe slight difference in some of the medications, for example, some promotilic agents that tend to be more in terms of the indication for CIC as opposed to IBS-C, but sometimes we still use those medications, particularly for patients who have severe IBS-C. As far as sort of clinicians concerned, we do have medications that improve bowel movements and constipation and diarrhea, for example. But we also tend to get more challenged when it comes to treating symptoms such as abdominal pain, discomfort, and bloating. And those are the main bothersome symptoms for patients as well. And this is basically the percentage of patients who complain of these symptoms, and that's the most distressing symptoms to the patients. I included the American College of Gastroenterology guideline in terms of the sort of definition and the diagnosis of IBS because it is the most updated guideline, but essentially the Canadian guidelines have the same sort of approach. Again, you can and you should make positive diagnosis of IBS based on Rome 4 criteria. And it's not like, well, I do think you have IBS, but let me send you for a colonoscopy. Colonoscopy is not required to make a diagnosis of IBS. If you do meet the criteria based on Rome 4 criteria, you have IBS, as long as you do not have any concerning symptoms, or you do not have any symptoms that make me as a clinician suspectful of another disorders, for example, celiac or something else that could mimic symptoms of IBS. But that's really based on clinical judgment. So if someone has what we call red flag symptoms or alarm features, such as anemia or recurrent rectal bleeding, or there's a sudden change in the symptoms, particularly if they're older than the age of 50, If they do have a strong family history of inflammatory bowel disease, colorectal cancers, or celiac disease, and there's a significant unintentional weight loss, so more than 10% compared to the baseline weight in the past 6 months have been lost, those alarm features would certainly require further evaluation, ideally by a gastroenterologist. But if the patients do not have any of those alarm features, they've had long-standing history of symptoms that they meet the criteria with the abdominal pain associated with defecation and change in the frequency and the consistency of the stool, they meet the criteria for irritable bowel syndrome. And you have to make a positive diagnosis of IBS so the patients don't spend 10 years without having an answer and moving to the treatment option. Patients may also have other chronic pain syndrome, but it doesn't mean that those syndromes or those disorders are causing irritable bowel syndrome. Could certainly confound the underlying IBS type symptoms, but it's not the cause of the IBS. Often patients have coexisting headache, migraine, interstitial cystitis, endometriosis, fibromyalgia, depression, anxiety, and many other disorders that could coexist with IBS. So I'm going to talk about sort of the pathophysiology of IBS as much as we know, and I think there's a lot more evolving in the field, and I'm glad to see the literature moving on this topic. But I'm going to tell you a little bit about what we know. So basically, the whole IBS can start from when we're in utero. So we have the exposure to various environmental factors and also psychosocial factors. If there is any history of trauma, particularly for the mother, it can actually affect the fetus in the uterus as well. Any infection, any antibiotic exposure at a young age, and of course, the psychosocial support and behavior can certainly impact the development or evolution of IBS in an individual. We are what we eat, so our diet plays a huge role in symptomatology of IBS, particularly as we tend to evolve more into kind of like ultra-processed food, fast food, eating on the go, high carbohydrates, high amount of starch and FODMAP, and I'll come back to that in a second, high amount of fat, particularly animal-based fat or saturated fat or trans fat. Those have shown to have negative impact on our gut. We live in symbiosis, sort of this happy medium with the bacteria or the microbiome that live in our gut. But those bacteria in our gut actually serve a very important purpose because they degrade the undigested food that is not food for us, that doesn't get absorbed in our body. But in the process, they generate all sorts of things, short-chain fatty acid, monosaccharides, all sorts of gas, including hydrogen, methane, carbon dioxide, and it also affects the bile acid secretions in our gut. So throughout that process, if there is any perturbance in that nice sort of happy medium of microbiome, it can definitely impact IBS symptoms as well. And then we have the whole axis of central nervous system, autonomic nervous system, and enteric nervous system. So essentially, you have a whole set of brain in your gut, and that's called enteric nervous system. And that enteric nervous system communicates to a very complex connection with your brain, which can then affect the gut motility, how we respond to certain insults in our gut, whether it's infectious gastroenteritis or a little bit of inflammations and so on. And that could then drive those centrally mediated symptomatology, and I'll come back to that in the next slide. So it's very complex, and as you can see, there is no easy fix to the problem of IBS when there's so many different things that can affect that symptom evolution. I think this is a very important slide because it can really explain as to why we use some pharmacologic options that later on I present in my talk. So on the left-hand side, this just demonstrates a part of the bowel. And you have a balloon, and that could essentially be anything. Let's say you have an infection, or if there was a bout of, viral flu or C. diff infection, or whatever the case may be. In this picture, they used to actually do a study called barostat, where they put a balloon in the bowel, and they would inflate the balloon and see at what threshold the patient would experience pain. And they've done this study with patients with irritable bowel syndrome, and they noticed that at a much lower volume volume compared to someone who doesn't have IBS, the patients with IBS actually does experience the pain. So in general, with the normal sort of cascade is that if you have an insult at the periphery, meaning at the level of the bowel, that signal gets communicated through the dorsal root ganglion, the spinal cord, and then through these pathways then travel up to the brain that is perceived as pain. That's a protective mechanism. Your body is trying to make sure that you're not affected by anything that is going to affect your health and well-being overall. And if those signals are inappropriate, then they're inhibitory signals that are communicated from your brain down to the level of the gut and says, nope, turn that off. That's not an appropriate response. Now, if there is an insult at the periphery, now imagine that insult has been removed, but then if there is this constant sort of signal between the periphery up to the brain, now you lay down these nerve pathways that are inappropriately firing signals to the brain. And in patients who have this sort of centrally mediated chronic abdominal pain, there is an imbalance between these excitatory input to the brain and those inhibitory input that are supposed to go down to the level of the spinal cord to shut off that inappropriate signal that have been firing. And then if you actually pay attention to these sort of descending pathway or the pathways that are coming down from the brain to the level of the spinal cord, you actually see that these are mediated through the chemicals, neurochemicals, or tiny little signals that are basically communicated in between through these opioid receptors, serotonergic receptors. So these are serotonin mediated receptors, noradrenergic receptors. So the medications that we use that targets the centrally mediated pathways include, for example, tricyclic antidepressants, SSRIs or SNRIs that, yes, have been historically used to treat mental health, but you actually see why we use it in GI, in gastroenterology, because we're really trying to get to the root of the problem to treat this centrally mediated pathway. And of course, you have sort of, modulation by various psychological distress, major life stressors, poor psychosocial support, maladaptive coping strategies. All in all, can definitely contribute to these signals that are communicated between your brain and your gut, and hence the name of disorders of gut-brain interaction as opposed to functional GI disorder. I also want to touch upon this sort of functional abdominal bloating because I thought that this study was quite neat. This was a study that was published basically, again, grabbing someone who has irritable bowel syndrome and also someone who has dysmotility. So that motility-related issues really sort of impairing their gut motility. And they actually looked at the amount of the gas that individual with IBS has in their abdominal bowel loops versus someone who actually has motility related issues when their gut doesn't move properly. Because often what the patients with IBS may experience is that, oh, I feel so bloated, I have a lot of distension and gas, must have a lot more gas than someone else who doesn't have these symptoms. But in fact, the amount of gas content that was more than the normal individual was only about 20 cc more than someone who doesn't have functional bloating or gas. Whereas in someone who has motility-related issues, where the bowel doesn't move properly, that individual has about 3.5 liters more gas compared to a normal person. The reason why someone with IBS may actually feel bloated or physically distended is not the gas itself, but it's actually the diaphragm and abdominal wall muscle discoordination. We call it abdominophrenic dysonergia. It means that they don't coordinate or they don't talk with each other properly. So in someone who has this sort of functional bloating, again, your body kind of goes into fight-flight response. So what happens is that the diaphragm gets contracted. So when diaphragm contracts, it actually flattens. When it flattens, it pushes things down. Your bowel basically goes down, and then your abdominal wall muscle comes out. So you do feel distended, but it's not because you actually have more gas. So unfortunately, for this sort of dysonergia, there is no really good intervention or good treatment. Yes, there are some sort of like EMG targeted physio that some people do, but I find that that's not really easily accessible. So I always counsel my patients around implementing something called diaphragmatic breathing, where you could just There's lots of videos given by physiotherapists that basically essentially tell you how to breathe. Like we need to shut off that fight or flight response that we're constantly in that mode, which impairs how we breathe, impairs this diaphragm. And that has shown to be implicated in patients with IBS, in patients with functional dyspepsia, pelvic floor dysfunctions, and so on. The other component that I didn't show you here is that actually that pelvic floor dysfunction. Remember, we basically the whole abdomen, you have the diaphragm up top, you have the pelvic floor muscle at the bottom, and then you have the abdominal muscle that contains the whole thing in between. So if there's any sort of imbalance or discoordination between these muscles, you can have these symptoms. This is also another neat study that was a study published in 2023, the Translational Medicine, which actually looked at a human genome. We always talked about, do you have any family history of patients with inflammatory bowel disease, like colitis, ulcerative colitis, or Crohn's in your family? But we don't usually ask about family history of IBS or mental health disorders. But when you're looking at the genome, there's also an overlap between the genes that increase the susceptibility to depression, anxiety, and irritable bowel syndrome. That's why I said the existence of depression and anxiety doesn't cause your IBS, but you already may have genetic predisposition to it, and it could certainly impact or worsen the symptoms of IBS. Another neat study that they did in 2020, they literally took the microscope to the level of the bowel and looked at the colonic mucosa, or the colonic lining, under the microscope. And they could see that the patients who have irritable bowel syndrome, they actually have 6-fold higher prevalence of microinflammation. So this is not the inflammation that we can identify at the level of the colonoscopy. This is at the level of electron microscopy. So much, 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 much higher resolution to look at the individual cells. And definitely there is some evidence of microinflammation. But again, we don't really have any therapy at the moment to target towards that microinflammation for patients with IBS. So I give you a lot about sort of pathophysiology, but just to kind of, again, reinforce as how complex this whole disease is. And that's why we don't have one easy solution to address this condition. This is just essentially an algorithm that myself and 11 other Canadian gastroenterologists came up with in order to kind of give a bit of a roadmap to family physicians and other healthcare allies who could use this to essentially initiate therapy, so the patients are not waiting to see a gastroenterologist 2 to 3 years and suffering in their symptoms. So then this way they could actually start treatment. And really, we talked about the Rome criteria. We talked about those red flag symptoms. We talked about limited laboratory tests if indicated. And then moving on to the treatment. And treatment for all my patients with disorders of gut-brain interaction starts with lifestyle modification. Okay, irrespective of what you're dealing with, lifestyle modification can improve some of the symptoms. So we'll talk about the dietary intervention, overall wellness, so good sleep hygiene, eating regularly, remaining physically active, of course, to relaxation therapy, whether it's yoga, exercise, whatever the case may be, and of course the mental health related therapies, for example, cognitive behavioral therapy, counseling, mindfulness, and so on. And then we'll talk about pharmacologic options that are available for each of these. Let's start with dietary recommendation. Disclaimer, I'm not a dietitian. I can only give you kind of like the breadth of the data that is available, but I think it's really important for all patients with disorders of gut-brain interaction, and in fact, all GI, gastrointestinal related disorders. Ideally, I would love to have a dietitian I could work with. And I think, again, it speaks to itself in terms of the areas that can be improved in management of disorders of gut-brain interactions, really to increase access to dietitian. And you hear often about all sorts of diets. Or should I do ketogenic diet? Should I do this anti-inflammatory diet? Should I go gluten-free? Should I do, Mediterranean type diet, low FODMAP diet? What do I do, doc? And you probably leave your doctor's appointment more confused than ever before, because we don't necessarily have the training that a registered dietitian have. So I really encourage everyone who can access a dietitian to ideally work with a dietitian if they're deciding to implement this. And of course, there are other resources that you could use in order to at least get started while you're waiting to see a dietitian. So that's why it becomes quite overwhelming and confusing. But I'll try to give you a little bit of a pointer around this sort of dietary intervention. This was a study that was literally published, I think maybe like 2 or 3 weeks ago, so hot off the press, that the hypothesis was that it seems like the prevalence of IBS is going up, coinciding when we started using more ultra-processed food in our diet. And they looked at about 200,000 participants in UK, and for as much as the patient could remember their dietary intake, they reported it. And they essentially had about 11 years of follow-up for these patients. And what they identified is that ultra-processed food consumption seemed to be closely related to incidence of IBS. For every 10% increment in the ultra-processed food consumption, there is an increased incidence of IBS by 8%. And those patients who had the highest amount of ultra-processed food consumption had a higher rate of IBS incidence. This whole idea of high fiber, low fiber, what kind of fiber do I do? I think it becomes actually quite confusing, simply because there's so many different types of fiber. We have soluble fiber, we have highly fermentable fiber, non-fermentable fiber, insoluble fiber. So you go to your doctor and doctor says, well, take more fiber. You're like, what kind of fiber? Right? Should I take soluble fiber? How much fiber do I take? Do I take 30 grams right off the bat? Like, what am I supposed to do? So I think it becomes incredibly confusing for everyone. So the general sort of recommendation is that you start at a low amount and you slowly increase the amount of fiber intake. It seems like particularly patients tolerate soluble fiber better than insoluble fiber. And the reason why this is so complex is because depending on what type of fiber you have, how much it gets fermented, the fiber can produce various amount of gas. Our body is not able to digest fiber. So the fiber actually gets digested by those bacteria in our gut. Throughout the process, they generate all sorts of things, short chain fatty acid, gas production. Of course, the gas contributes to the pain, bloating, flatulence. Depending on how much short chain fatty acid gets produced in the process, it can affect the microbiome itself. So it's basically a bidirectional relationship. It can affect the amount of osmotic load that you have, meaning how much sort of content you have in the gut that it can actually draw water into the stool, which then could affect the transit of the material through the colon. And if it accelerates it, you get diarrhea. If it slows things down, you get constipation. So it becomes quite complex. And overall, about 50% of the patients don't actually think that fiber really improved their symptoms. And we don't really have good quality evidence to really support the use of fiber, particularly insoluble fiber. So overall, the recommendation is that it's best to stick with soluble fiber, particularly if patient has bloating and gas. And if you're going to do it at a small amount and gradually increase it, because a fiber intake of 30 grams a day in our diet is actually quite hard to achieve. So you really want to kind of build on that tolerance. Otherwise, you're going to get more bloating and potentially diarrhea or even constipation. This was a really neat study where they looked at the basically 3 sort of non-pharmacologic intervention for constipation. They looked at the kiwi fruits, so 2 kiwi fruits versus 100 grams of prunes versus 12 grams of psyllium for 4 weeks amongst patients who had constipation or IBS-C. And these are the patients who had less than 3 complete spontaneous bowel movements per week. They had moderate abdominal pain. They had hard lumpy stool, difficulty with stool evacuation. So essentially, they did meet the criteria for IBS-C or CIC, or chronic idiopathic constipation. And you can see essentially all patients did notice an improvement with all these 3 interventions. But one thing that was neat was that when they asked the patient, are you satisfied with the therapy you took? The majority of the patients in the kiwi arm group said that they were actually more satisfied compared to the psyllium and the prune arm. And then when they looked at the adverse effect, the patients who were in the kiwi arm, a kiwi fruit arm, actually had less side effects, and they in fact did not have any abdominal pain or gas, and they're much less bloating compared to patients who are on prune arm. And prune also can contain high amount of basically FODMAP, so it can potentially contribute to the bloating and so on. So I generally recommend, instead of psyllium or prune or whatever, I usually say 2 kiwi fruits a day if patients are not allergic to it or able to find it. That actually shown to significantly improve constipation, particularly if it's mild constipation. I always get questions around, oh, should I take my kombucha? Should I take my prebiotic? Should I take my probiotic? Should I take my symbiotic? I just put up this slide because I want to show you the sort of the clinical evidence behind it. I like to practice evidence-based medicine because I know it does have implication in terms of the cost and, of course, like taking this probiotic or symbiotic every day. So if there's not a whole lot of evidence, I always tell that to the patients. Probably, when you look at actually the IBS, constipation and functional dyspepsia line, there's not a whole lot of evidence with all these probiotics, prebiotics, symbiotics, and so on. Maybe there is some evidence with fiber, which I alluded to earlier, but we often recommend it, but really there is actually positive data to support this in our clinical practice. So what are these low FODMAPs? We talked about it. So FODMAP stands for fermentable, which means it creates gas, oligo, di, and monosaccharides. So these are essentially just sugar or carbohydrates, and polyols. So these are basically gums, sugar-free gums, and so on. So these are poorly absorbed carbohydrates, so we don't digest it. It's food for the bacteria in our gut. And they actually draw more water in the small bowel, and they get rapidly fermented in the by the microbiome. And as a result, it produces gas, bloating, abdominal pain, and altered bowel habit. So the recommendation in patients who have IBS-type symptoms is to essentially try to avoid these FODMAPs. But you can see it's quite extensive. It's quite hard to follow. That's why I was saying it's really best to follow this diet with a registered dietitian who could really guide you through this diet. I often see that patients come to me and they're like, oh, I've eliminated everything on that low FODMAP diet, and I still don't take it. And it's been 2 years later. So that often actually worries me quite a lot, because it means that the patient has developed a very restrictive diet. And certainly the intention of this diet is not to trigger avoidant restrictive food intake disorder. That is one validated disorder that we often see in patients with disorders of gut-brain interaction. The whole intention is that you do the elimination for a finite number of weeks. So 2 to 6 weeks. If you don't see any improvement after 2 to 4 weeks, this is not the right diet for you. It's not a panacea for everyone with disorders of gut-brain interaction. So you do the elimination, and then you have to start reintroduction. That's where the dietitian could really help out, because it really helps you with how you're supposed to reintroduce all that you've eliminated in your diet. Generally, the rule of thumb is that you reintroduce one item at a time, maybe 2 to 3 days, with the least bothersome one first, and then you move on to the more bothersome ingredients. And then you get to the customization or personalization phase, that you identify, okay, like I cannot tolerate any garlic in my diet. I have to completely avoid that. Or I can only take a small amount. That's where you basically get the fruit of the labor that you did with the low FODMAP diet, which I think it's quite hard. That allows you to identify your triggers. And again, I would say 50-60% of the patients with IBS diarrhea do actually notice an improvement with low FODMAP diet. But it is not an easy diet, and I certainly don't want someone to go on it and restrict their diet for months or years at a time. These are just some of the resources I included in terms of what are the FODMAP, like what should I eliminate, what do I take? I'm happy to share these resources with you afterwards. And I do have a list of resources I'll come to in a second, but I just also wanted to touch upon this notion of fructose and fructans, particularly with prepackaged food, food that is like easily accessible. These sugars can easily kind of sneak into our diet. And a lot of time people say, I don't have celiac, but I want a gluten-free diet. And by virtue of eliminating a gluten-containing diet, a lot of patients are actually eliminating fructans from their diet too, but they think that it's the gluten-free diet that is helping them, whereas in fact, they actually reduce the amount of fructans in their diet and they do notice an improvement. So just be mindful of that. And then this has shown really the fructans and fructose could significantly contribute to abdominal pain, wind, bloating, nausea, and global symptoms of IBS. So these are just some of the resources that I included. Their mobile app, Monash app. Monash is the university that came up with low FODMAP diet. There is a recipe book by this dietitian that I actually followed on Twitter, and I found that her resources are actually quite useful. I don't get any benefit back from you buying this book or downloading it, but I thought that her resources were actually quite helpful. So moving on to more now pharmacologic options. So we talked about, again, lifestyle modifications or dietary changes. Now then it's broken down to whether you have IBS-C or you have IBS-D. And with patients who have milder symptoms, certainly over-the-counter medication could make wonders. And of course, you have, antispasmodic like Buscopan, Diacetyl, peppermint oil, like for example, IBGAR that is over the counter, digestive enzymes, all those things. I'm totally up for it if you have mild symptoms. And you could also use it as a sort of adjuvant, like add-on therapy if you have more symptoms. And then we also have medications that have been approved in Canada for specifically management of IBS constipation and IBS diarrhea. And these are the medications that are prescription medications. And then again, if you have ongoing symptoms, sort of the other arm that we talked about, the centrally mediated pathway with use of, for example, tricyclic antidepressant and cognitive behavioral therapy could certainly be, again, another layer of intervention for patients with complex IBS. So let's talk about IBS-C treatment options, so medications that are approved. I'm going to show you a lot of these slides that have pictures like this, so I'll try to break it down and make it a bit easier to understand. With this class of medication called guanylate cyclase C agonists, so these are essentially secretagogues. So they stimulate the bowel to secrete fluid. When you secrete water and electrolytes into the lumen of the bowel, it actually adds bulk to whatever is in the lumen, and your colon then, or your small bowel then continues to do these peristaltic contraction, kind of like these milking motion that pushes things forward. So as a result, it improves the constipation. So two medications we've had linaclotide or Constella has been around for years now. And a few years ago, we had plecanatide or Trulance that were approved. Both work on similar sort of pathways. So they bind to these receptors, the guanylate cyclase receptor. They increase a bunch of intracellular, basically, channels and receptors, and then it secretes chloride into the lumen through this channel called CFTR channel. That's just the name of the channel. Anyways, but the sodium, once you have the chloride, it's a negative ion inside the lumen. The salt is created. So the sodium follows. You have salt. Anywhere you have salt, water follows in the body. So you actually stimulate water secretion inside the lumen, add more bulk to the content of the inside the bowel, and as a result, you promote the secondary peristalsis or secondary contractions in the colon. And they also work on these pain fibers so that it reduces that firing I mentioned, because we know patients with irritable bowel syndrome do suffer from visceral hypersensitivity or the hyperactivity of these nerves. So not only it improves the constipation, it also improves the abdominal pain, which is what we want to have when we're approving a medication to treat IBS-C, because we want to treat the symptoms globally, not just the constipation, but also the abdominal pain, which is the main bothersome symptoms to a lot of patients. Plecanatide or Trulance is the other molecule that I was telling you that works through the same mechanism, and it actually mimics an intrinsic hormone in our body called uroguanilin. This hormone is secreted in response to eating. When we eat, this is actually secreted, so that actually stimulates our bowel to move and have a bowel movement. And they actually did a study in patients with chronic constipation. It seems like there are a certain percentage of patients who actually have reduced amount of uroguanilin in their body. So plecanatide is really neat because it only has one amino acid different compared to the intrinsic molecule that we have, or intrinsic hormone that we have. And by changing that a little bit, it actually binds to the receptor with higher affinity, and it stimulates the pathway that I mentioned, and it stimulates basically the electrolyte and the water secretion and increased bowel movements. And all these drugs are actually minimally absorbed. So it means that it stays in your gut and inside the bowel. It doesn't have much systemic absorption, and so it doesn't have any significant systemic side effects. For any of the medication to be approved, be it by FDA or the European equivalent of FDA, they need to show that they have this improvement in composite endpoint of improvement in both the abdominal pain, which is 30% decrease in the global symptoms with the abdominal pain, and also improvement in complete spontaneous bowel movement. So I'll show you some data to just show you the efficacy of these medications. When you look at plecanatide, in the two separate studies that they followed the patients for 12 weeks, the treatment arm with plecanatide was superior to placebo. And then when they also followed these patients 4 weeks after they stopped the medication, the effect actually lasted. So it did seem to improve the constipation, and that effect was actually lasting, although again, not probably for months at a time, because as I said, it doesn't get accumulated in the body. And you could see the improvement in the composite endpoint as early as the first 1 to 2 weeks after starting therapy, and that effect is sustainable. So it's not like you take the medication after 2 weeks to develop tolerance to it. So it did have that separation between the treatment arm, which is the blue line, and the gray line, which is the placebo arm. And it also showed improvement in the abdominal pain, which again, as a clinician, as a patient, anything that improves the abdominal pain and bloating, I think it's a win-win in management of IBS. And you could see that separation again as early as 2 weeks, and it remained statistically significant in the treatment arm compared to the placebo arm. This is just similar sort of graph, but for linaclotide or Constella, and you could see that it also improved the abdominal pain, complete spontaneous bowel movement, and combined response. So that was the improvement in both the abdominal pain and complete spontaneous bowel movement, and it was superior compared to placebo. Of course, any medication we take comes with potential side effects. The most common side effects for these medications are obviously diarrhea and abdominal pain and flatulence. But the other symptoms, they're quite mild. There's no severe or serious side effects associated with this medication. There's the third medication called Ipsarela or tenapanor that works on a slightly different mechanism, just works on a different channel, and it actually inhibits the uptake of sodium from the lumen. And by virtue of inhibiting the sodium absorption, you essentially, again, maintain the water within the lumen. It also seems to improve the sort of connections between the cell lining of the bowel and this whole notion of leaky gut. I mean, again, there's a lot of sort of misinformation around it, but it seems like to also improve that tight junction. And we know that in post-infectious irritable bowel syndrome, there's definitely some sort of insult to that integrity of the bowel mucosa. So it seems like it improves this tight junction. And just like the other two medications I showed you, it also does decrease the visceral hypersensitivity, which is a major part of symptom generation in IBS with manifestation in form of abdominal pain. With Ipsarela, it also showed that the overall response was superior compared to placebo. About 37% of patients treated with Ipsarela actually demonstrated overall response with improvement in their abdominal pain and complete spontaneous bowel movements. And in fact, they were able to have on average about 3.5 complete spontaneous bowel movements per week. And these are the patients who actually started with less than 1 complete spontaneous bowel movement per week. So there was a significant improvement with this medication. And about 54% improvement in abdominal pain score, which is significant for any medication to improve 50% abdominal pain when it comes to IBS. I think it's quite remarkable. And same thing holds true for the abdominal bloating, as I showed you earlier, is probably one of the most common symptoms that the patients find distressing. And there was about 50% improvement in abdominal bloating. And overall, 41% improvement in mean quality of life score compared to the baseline in the treatment arm compared to placebo. Same holds true in terms of the side effects with constipation, with this medication for constipation includes diarrhea, abdominal distension, flatulence, and so on. So I talked about the pharmacologic option. I just added this because I just want to show you the innovation that goes in this field. And this was a sort of a vibrating capsule, a colon-stimulating capsule that was approved by FDA in 2022. And I believe it is available in the United States for treating of constipation. It's not available for IBS-C, but these are the patients who have severe constipation. And again, depending on essentially the frequency of the capsule causing vibration, you can actually stimulate the peristalsis in the colon. So this was a positive study that was published, and I think it's approved in the United States, not yet in Canada. Before we move on to IBS diarrhea, I wanted to point out an area of diagnosis, essentially a paradigm in constipation that is often under-recognized. And this graph seems quite daunting, but I'll try to simplify it. So we talked about, again, from the top, constipation. You do relevant blood tests or if colonoscopy is indicated or structure evaluation as appropriate. Not everybody, again, needs these evaluations. We talked about dietary modification. We talked about over-the-counter stuff, osmotic laxatives, and so on and so forth. Usually, if the patients try various laxatives without significant improvement, then you always wonder whether the patient actually has an underlying defecatory disorder. So in order to be able to have a bowel movement, it takes actually a lot of coordinations and relaxations with the muscle. So again, going back to the pelvic floor, the anal sphincter and also the coordination between the abdominal wall muscle, all in all, is really important to be able to expel the stool. So the anal sphincter needs to relax, the pelvic floor needs to relax, the person needs to generate enough pressure in the abdominal cavity in order to basically generate the force behind the stool to get the stool out. The analogy I use for the patients who have defecatory disorder, who often basically present with, I can't get the stool out. No matter how much I push on the toilet, and I turn red, and I feel dizzy and so on, and I still cannot get the stool out. Sometimes they need to use, finger disimpaction. They have to raise their legs or do all sorts of, maneuvers and sit differently on the toilet in order to get the stool out. The reason behind it is that, or the analogy I use is that, imagine that you have a toothpaste tube. If the cap is closed, no matter how much you push, you're not going to get the toothpaste out. It's the same sort of principle. You have to be able to relax the anal sphincter for the stool to get out. And that's one area that we often underdiagnose and under-investigate in patients who have these defecatory disorder. And in order to diagnose that, you need to have access to neurogastrointestinal evaluations with a test called anorectal manometry and the balloon expulsion test. So the anorectal manometry is done, again, in a hospital setting or in a clinic setting where you have a catheter that has pressure sensors on it. It's put across the anal sphincter, and it has a balloon mounted on top of that catheter that is supposed to mimic the stool inside the colon, inside the rectum. And you ask the patients to do various movement with, tighten the anal sphincter, relax the anal sphincter, try to simulate the defecation, kind of like try to bear down, and you're trying to see whether that pressure or relaxation or contractions are actually acting properly. And we can translate that pressure into color, and we see that on our screen, and essentially we see that coordinations between the pelvic floor and the anal sphincter. And if there is any abnormality, whether that the patient cannot relax the anal sphincter completely and or they cannot generate enough intra-abdominal pressure, the treatment really boils down to what we call biofeedback. So it's not laxatives. I can pour tons of laxative in someone. If someone cannot get the stool out, the stool is not coming out. So really the intervention is to target what the problem is in individual patients and essentially retrain the pelvic floor and the brain, and essentially you're retraining the body how to get rid of the stool, how to defecate. And there are various modalities. For example, we have MR enterography, or we have the barium defecography, these are dynamic tests that looking at that sort of coordination and synergistic relaxation contractions, depending on what part you're looking at, in order to see whether or not the patient's able to get the stool out. Unfortunately, this is one area that we don't necessarily have easily access to it. Once again, in our province, I don't think there are that many sort of experts with biofeedback in the province, so it becomes really challenging. Even if you diagnose someone with this disorder, it becomes a bit of a challenge as to where to direct them to access appropriate therapy. I'm going to shift and talk briefly about IBS diarrhea pharmacologic options. We really have two medications that have been approved for treatment of IBS diarrhea. You may have heard of rifaximin. Rifaximin is a non-absorbable antibiotic. It's very minimally absorbed. Essentially, it targets the gut and the microbiome, and it seems to reduce the bacterial load and hence reduce the bacterial toxin. And as a result, for example, the intraluminal gas and all the byproducts that I showed you earlier on that the microbiome produces is reduced, and it can actually help abdominal pain, bloating, and diarrhea. There were two studies that were initially published. These are actually quite old studies in 2016, looking at rifaximin versus placebo, which again showed both the diarrhea and the abdominal pain. The other medication that has been approved is called eluxadolin or Viberzi, which works through the opioid receptor, but it does have a mixed agonist-antagonist. So it binds and stimulates certain receptors, binds and inhibits certain receptors along the opioid pathway. And it has shown to predominantly improve the abdominal pain and urgency, and to some extent the diarrhea in patients with IBS diarrhea. In patients who had previous removal of their gallbladder, and or if they've had prior history of pancreatitis, it's actually contraindicated because it's shown in the clinical trials at least that it could increase the risk of pancreatitis and increasing the liver enzymes in those patient population. And also in patients who drink more alcohol than recommended. And now with the new consensus is that less than 2 units of alcohol per week essentially is what the maximum amount of intake should be. There was another medication called allosetron. Previously, it's no longer accessible because of the risk of ischemic colitis. But instead of that, in patients who have severe IBS diarrhea, sometimes I use off-label ondansetron or Zofran, which is actually a medication that is given for nausea and vomiting in the context of chemotherapy, but it belongs to the same class of medication, and it doesn't have the more serious side effects that allosetron has, and it can actually be quite effective in patients who have severe IBS diarrhea. I'm going to wrap up my talk by just touching upon these sort of medications for basically the centrally mediated part of the story with IBS diarrhea. And again, these are the medications that have been historically used to treat various mental health disorders. And I'm going to preface it by saying that I'm not a psychiatrist, and I certainly don't claim that I know how to use these medications. And certainly, however I use it is really limited to the data that we have in the gastroenterology literature. But certainly there is enough data to support the use of these medications. And of course, I often love to have a psychiatrist or a psychologist or a family physician involved in co-management of my complex IBS patients. In patients who suffer from severe anxiety and depression, as I said, it's not the anxiety and depression causing IBS, but it could certainly confound their underlying gastrointestinal symptoms related to IBS. So if there is significant anxiety and depression, I think it's important to address that and see whether that by itself improves the IBS symptoms as well. So generally medications like sertraline or escitalopram belong to the class of SSRI, have been recommended to be used in that context. I tend to use fair amount of TCAs or tricyclic antidepressants like nortriptyline, amitriptyline, desipramine, imipramine in my practice because I find that in patients who suffer from insomnia or difficulty with sleeping, particularly if they have significant diarrhea or abdominal pain, a low-dose amitriptyline or nortriptyline can be quite helpful. Mirtazapine, one of the tetracyclic antidepressants, have been shown to improve chronic nausea, vomiting, functional dyspepsia, which is again out of the sort of scope of this talk, and particularly if someone has significant weight loss and disturbed sleep after obviously they've had appropriate workup and they don't have any other explanation for their weight loss, that has shown to significantly improve their upper GI symptoms. And in patients who experience side effects from TCAs, sometimes we use SNRI as well. Again, that's something I would really rely on family physician to help me out to start patients on, and I would like the patients to actually see their family doctor within a week or two to make sure they're tolerating the medication well, and or if the dose of the medication needs to be adjusted, that it would be done accordingly in conjunction with their primary care provider. And of course, there are various other sort of medications you see that is used as augmentation. So essentially, we're adding layers to this sort of complex multidisciplinary approach. And then on the side, we certainly have the psychological treatments, which has shown to be significantly beneficial to treat centrally mediated abdominal pain, including cognitive behavioral therapy, mindfulness, hypnosis, again, giving the patients the ability to cope and learning these coping strategies, because a lot of these symptoms can be due to poor psychosocial support or maladaptive behavior, and these will certainly empower the patients to implement those techniques. Just the evidence behind amitriptyline, because this was a study that was published recently with Atlantis trials showing the effect of amitriptyline at 10 to 30 milligrams at nighttime, actually continued for about 3 months, compared to placebo, was significantly superior in overall improvement of global symptoms of IBS, including diarrhea, abdominal bloating, pain, and distension. And when you compare the side effects, because it's a low dose, 13% adverse event in amitriptyline arm versus 9% in placebo or sugar arm. And those side effects include dry mouth, urinary retention, some drowsiness, and blurred vision. Generally, I use it at bedtime and I take advantage of that, particularly, as I said, in patients who have difficulty with sleep. So again, just take a balcony view. We talked a lot about sort of dietary modification. We talked about, over-the-counter stuff and even like antispasmodic, like dicyclomine or dicetel or buscopan. We talked about specific medications for IBS-D and IBS constipation that have been approved in Canada and also by FDA. And of course, neuromodulation, which works more towards the centrally mediated pathway, and of course the psychological support. So you can see that how complex and challenging this may be, and you really need to have a multidisciplinary approach to a complex disease like IBS. This is just showing you kind of like, again, that pyramidal approach base of this sort of fundamental aspect of the intervention and management comes with dietary changes, exercise, mindfulness, relaxation techniques, sleep hygiene, and of course the various pharmacologic options and non-pharmacologic options that we talked about. Thank you.
Thank you so much. So you can have a look at the questions. I think you have 65 questions.
All right.
In your Q&A.
All right, so I'm gonna try to quickly go over these questions. All right, so there are some questions around diarrhea, whether this is overflow diarrhea or regular diarrhea. That I think is a very good question. I think this is something that needs to, again, boil down to the history. So if someone provides me with a history that they don't have any bowel movements for 3 or 4 days at a time, and then they go and they have a lot of loose stool, and they're going to start having some form stool in between, that makes me wonder about overflow diarrhea. Sometimes I order an abdominal x-ray, even though it's not exactly the best modality, to just see how much stool there is there in the bowel. Often patients, as I said, present to the emergency setting. A lot of times these patients have had CT scans, so I might actually look back at the CT and see whether or not they commented on fecal loading. And also, if the patient's, in the clinic, sometimes actually doing a rectal examination can be helpful. If the rectum is full of stool or impacted stool, then that kind of gives me an idea of that this is more likely in keeping with overflow diarrhea. But that's, again, it can become a bit of a challenge, but I think it's really important to take a good history in order to be able to differentiate between the two. There's some questions around sort of, gut permeability and microbiome. Honestly, that's a whole talk on its own. It's suffice to say that unfortunately, we don't really have very robust tests to assess the small intestinal bacterial overgrowth. Often the patients come to me and they're like, I was diagnosed with SIBO. To me, it's more like, what does that mean? Because SIBO is an epiphenomenon. It's not an isolated diagnosis on its own. Unfortunately, many patients are diagnosed with SIBO by their naturopath. And I always remind patients when I look at the breath test, a lot of the breath tests actually give me numbers that to me, it means that their equipments are not actually calibrated properly. So you always take that breath test with a bit of a grain of salt. Usually small intestinal bacterial overgrowth is something that we see in patients, for example, with underlying gut dysmotility. If they have connective tissue disease like scleroderma, if they've had previous abdominal surgeries, if they have adhesions and so on and so forth, Crohn's disease, or something that increases the possibility of small intestinal bacterial overgrowth is more likely. However, we know that for sure the microbiome disturbances and small intestinal bacterial overgrowth could coexist in patients with irritable bowel syndrome, but often the symptoms can overlap. So until we actually have good quality breath testing that is done in our life lab, where we know that the machines are calibrated properly and it's a legitimate test that I could rely on, it's really hard to say that a truly SIBO based on breath test is actually a valid or not. So having said that, I mean, if someone is interested to explore the options of microbiome, with changes in the dietary aspects, or for example, rifaximin in treatment of IBS diarrhea, I think it's still a reasonable approach as long as, the limitation is recognized. Are there any motility drugs known to improve or repair the permeability of the gut lining? Not that there's any drug that is available with enough evidence to support the use in basically improving the gut permeability. The only study that sort of published that looked at particularly post-infectious irritable bowel syndrome, which can potentially impair the gut, as I said, barrier mechanism, was with glutamine, which is an amino acid that's shown to, at higher dose, like 5 grams, I think 3 times a day up to 8 weeks, is shown to improve the abdominal pain, bloating, and diarrhea in patients with post-infectious IBS. And if the patients don't have significant chronic kidney disease, it's something that could be considered, but there's no specific drug yet for gut permeability. Yeah, I think someone's asked about the gut-brain microbiome access. So basically, as I said, the whole pathophysiology of IBS is very complex. It falls under the realm of gut-brain disorders of gut-brain interaction, but we know that microbiome could certainly impact this. So the access is actually more sort of comprehensively referred to as gut-brain microbiome access. But we're talking about disorders of gut-brain interaction based on Rome-4 criteria and the IBS that falls under the realm of disorders of gut-brain interaction. Is there anything to do to help someone heal who has been on antibiotics long term? That's a difficult question because obviously, certainly, antibiotic could negatively impact the microbiome. Again, as I said, there's not a whole lot of evidence with probiotics, but it is something that can be considered. But generally, if you take probiotics for, let's say, I don't know, 3 or 4 months and you feel like, okay, it didn't make any difference. Again, we don't know which kind of bacteria you're missing in your microbiome that we could then target it accordingly. So it becomes a bit of a test and trial more than anything else. But multi-strain probiotics that contain lactobacillus, bifidobacter. Those are the ones that I've shown to have some benefit when it comes to gut health. But as I showed you, again, the evidence with it is quite low. Sorry, I'm just trying to read through some of these questions. Someone asked about a talk on functional dyspepsia. Certainly, I'm happy to do that, except it's one of the areas in GI that unfortunately I feel that the needle hasn't been moved much when it comes to research or even pharmacologic options. So in terms of the pharmacotherapy, we're still quite limited, but it does have certainly a lot of overlap with IBS. Of course, the medications that are presented for management of IBS diarrhea and IBS constipation can't really use it for functional dyspepsia. Women versus men IBS, I'm not sure what that question is alluding to, but IBS is the disorder that can affect essentially both women or men. And the prevalence of it seems to be higher in women, and whether that's related to hormonal changes or whatnot, we don't know, but we certainly do see it more in women than in men. There's a question around magnesium. In general, magnesium or any osmotic laxative, so magnesium, PEG laxative, so that's Laxative, Restoralax, Miralax, all those medications over the counter, they're still considered quite safe and effective to be used for management of chronic constipation. They do not improve global symptoms of IBS. As I showed you data around the visceral hypersensitivity, we know that PEG laxatives don't necessarily target specifically the pain aspect of IBS, but by virtue of improving the constipation, offloading some of the stool that is built in the bowel, you can actually improve some of the symptoms of IBS, but it's not meant to treat the global symptoms of IBS. What's the difference between IBS and IBS and IBD? So IBS is irritable bowel syndrome, whereas IBD is inflammatory bowel disease. So that's ulcerative colitis and Crohn's disease. So these are the patients who do actually have inflammation, ulceration, bleeding, and we do see abnormality during the time of colonoscopy. So whereas with IBS, we do not see any abnormality on colonoscopy that's going to give us a clue that the patient has IBS. So as I said, there's no biomarker, there's no diagnostic test for IBS. Can pregabalin be helpful for IBS diarrhea? The data around pregabalin or gabapentin in management of abdominal pain is actually quite limited. However, I mean, it is medication that's been used to treat neuropathy, and we know that neuropathy may actually contribute to some of the symptoms of IBS. But specifically for IBS diarrhea, we don't have enough data to show that it is particularly helpful. Do antidepressants make the gut symptoms worse? Again, that's a very broad question. I don't know what type of antidepressants you're referring to. There are definitely some antidepressants that can have GI side effects. For example, SSRI themselves that I talked to you about in management of, anxiety and depression, if that's what really contributing to the IBS itself, could certainly be associated with diarrhea. And then the TCAs I showed you that we use in management of IBS, particularly IBS diarrhea, can actually cause constipation. So it depends on what antidepressant you're referring to, but a lot of medications have GI side effects. So that's unfortunately the nature of the medications. Is intermittent fasting a good thing to do for IBSD? Intermittent fasting has become one of those fad diets, unfortunately. I mean, it does have its own benefit. Essentially, what it does, it restores these, what we call housekeeping waves in your bowel, that they come and clean your bowel. And there's some sort of maybe very low grade, weak evidence that you need to have these what we called housekeeping waves to come and make sure they clean the bowel so there's no residual debris, so it doesn't provide an environment for the bacteria to overgrow in your small bowel, because your small bowel is technically an environment where there's not a whole lot of bacteria growing, and if there is an impairment in these housekeeping waves, those debris in the small bowel could provide an environment for the bacteria to ferment and live and munch on these sort of residual debris. So intermittent fasting seemed to kind of enhance that sort of housekeeping waves, and as a result has shown to basically help with the maybe reduce the risk of developing small intestinal bacterial overgrowth. But by no stretch of imagination, I'm recommending intermittent fasting to treat IBS diarrhea. The algorithm for the IBS diagnosis has been made available to family physicians, and I believe it's on BC Pathways, if I'm not mistaken, but that could easily be shared with the family doctor. Kiwi makes my tongue itchy. Yeah, I mean, there are some patients who do have the oral allergy syndrome, so kiwi may not be the best therapy for those patients. Certainly, if you have any allergic type reaction, maybe kiwi is not the best option for you. What is the consistency of normal for frequency of death? So this is actually an interesting question. So what is normal? If you actually look at the study that was published, I think quite a long time ago, anywhere between 3 bowel movements a day up to 3 bowel movements a week is actually considered normal. So it depends on, again, the deviation from the normal. What is your normal? So the different people's normal is different, even though that you have this wide range. And when you look at the stool consistency, you actually look at something called Bristol, like the city Bristol stool classification. And now we have 1 to 7 Bristol stool, and anywhere between kind of like type 3 and 4 is actually considered normal. But again, the number of it is a bit of a wide range. Is there a link between other conditions like GERD or EOE and IBS? Now, EOE is a little bit of a different kind of entity, the eosinophilic esophagitis, and it does have some type 2 immune-mediated reaction to it. But gastroesophageal reflux disorder is technically one of these, we call it a functional GI disorder, if you may. But it does have a bit of a different pathophysiology. But as I said, GERD, IBS, functional dyspepsia, these sort of disorders can certainly coexist. If you've been on a gluten-free diet for 10 years plus for relief of constipation, can you introduce gluten safely? As long as you don't have celiac disease or any previous known allergies to gluten, you could technically slowly reintroduce it. Now, how you tolerate it, that's again a different question. But if there is no prior history of allergies, certainly you could start reintroducing it in conjunction with your family doc or a dietitian. Is IBS-C linked to colon cancer? So there was a study that was published recently that actually showed that patients who have IBS actually has lower prevalence of colon cancer. And this could be due to the fact that, again, these patients often do come to the attention of medical care. They get various imaging, they get frequent colonoscopy, and that's probably that detection sort of aspect of things that perhaps reduce the risk of colon cancer in this patient population. Yeah, dietitian referral. I understand that it's, as I said, the access is quite limited. I do believe that there are some dietitian programs that are in the hospital where patients can be referred, but I full-heartedly echo the limited access to dietitians and unfortunately the cost that is associated with it. Yeah, so there's a question in the chat regarding the withdrawal of amitriptyline. So any of these medications, unfortunately, you can't stop it abruptly. because you can potentially get a bit of a rebound side effects, particularly with SNRI. People can get significant abdominal pain and other type of withdrawal symptoms. So I always recommend that to be done in slowly under the guidance of the family physician to make sure you don't get a rebound effect. Pancreatic enzymes. Yeah, there are lots of sort of digestive enzymes over the counter with various strengths. Again, there are some patients who may have pancreatic enzyme insufficiency, depending on, again, other sort of pathologic disorders that they may have, like chronic pancreatitis or whatnot, that they would certainly benefit from prescription dose pancreatic enzyme. I sometimes use digestive enzymes in my practice. If someone says, I take digestive enzymes and I feel better, again, it's really hard to know, is this truly the pancreatic enzyme or digestive enzyme that is really helping, or is it a bit of a placebo effect? Placebo effect can actually be up to 30 to 40%. So we do always need to take that into consideration as well. But excess amount of digestive enzyme at sort of over-the-counter dose is probably unlikely to cause any harm. But very high dose of it could certainly have some side effects. How do you know it's abdominal gut pain instead of muscle pain? I think that's a very good question. I often do get, again, referral for patients who have had very focal abdominal pain. And then when you ask the patient, say, where is your abdominal pain? They could literally point with one finger where the pain is. That is usually not gut-related pain. If you could literally pinpoint finger with your abdominal pain. And there are actually signs on physical examination that your family doctor or your specialist can do. We call it a Carnet sign. So essentially, we ask the patients to basically tense up their abdominal muscle. So you put your hand wherever the pain is, you lift up your head or you lift up your legs, and someone resists against your leg trying to basically keep your, while you're trying to keep your leg up. If that intensifies the pain, that is likely related to muscle pain. And you can get these sort of superficial nerves which go to the abdominal wall muscle get trapped, particularly around scars or if they have previous history of abdominal trauma, and that could contribute to abdominal pain. And no imaging technique or endoscopy or anything like that would actually identify that as a cause to the pain, other than a good history and physical examination. Where does methane SIBO fit into this? So that's also another talk on its own. But we know that methane could certainly contribute to constipation. It actually slows down the colonic transit. And it's not really SIBO because it's called IMO, or intestinal methanogenic microorganism overgrowth. That could certainly exacerbate constipation. And again, goes back to my initial point I made about the breath testing. Until we have reliable breath testing, and we know that we're following the consensus recommendations before we do these breath tests, it's really hard to say, or is this IBS-C or is this IMO that we're dealing with. So that's, again, one of the other areas that we don't necessarily have, unfortunately, enough resources and appropriate testing in order to provide targeted therapy. Is prucalopride one of the medications discussed? I didn't discuss prucalopride because it's a promotylic agent. It's a very good medication because it essentially can affect the motility of the entire GI tract. It was also used in patients with gastroparesis or delayed gastric emptying, and it also promotes the small intestinal movement as well. I tend to use it in patients who have severe IBS-C in conjunction with other medications I showed you. It's a totally reasonable medication to use, except in the clinical studies that they did with prucalopride. It was not powered enough to show an improvement in abdominal pain and hence the global symptoms of IBS. That's why it was never approved for IBS-C, but it could certainly improve the constipation. And as I said, in patients who have severe IBS-C, sometimes I use prucalopride in conjunction with another pharmacologic options that I showed you. Yeah, the kiwi fruits, again, skin on or off. If you can eat it with the skin on, be my guest, but you can also peel the skin. I thought rifaximin was specific for constipation. Rifaximin was actually approved for IBS-D, but there are some studies showing that a combination of rifaximin with another antibiotic can help increase in methanogenic microorganisms as well. But again, that the data with that is not as robust. That's why it's not approved for management of constipation. What if we can't? Yeah, access to anorectal manometry unfortunately remains quite limited. I'm pretty much the only gastroenterologist in the province who has access to anorectal manometry and appropriate training to do it. And unfortunately, we only have one GI motility lab at St. Paul's who has anorectal manometry. So the question is that if we know that we have this sort of defecatory disorder, what are we supposed to do with it? So certainly if you have access and ability to work with a pelvic physio to do the biofeedback, that's really the best intervention for patients with dyssynergic defecation. And as I said, the laxatives don't necessarily improve that. So rather than waiting for anorectal manometry, I don't think there is any harm in doing biofeedback. Now, the quality of the biofeedback, I can't really comment on, but certainly if someone has expertise in the area that can provide biofeedback, I think that's going to be quite beneficial. There are definitely apps where you could do this sort of hypnosis and mindfulness and cognitive behavioral therapy. I think Mohana is the only app that was FDA approved, but there's Nerva and a bunch of other apps for hypnosis and mindfulness. I certainly think that those are very good resources because obviously we also don't have access to GI psychologists or experts who could provide these interventions regularly, and it can be quite costly. So I certainly support any of those apps that have shown to be beneficial. In terms of side effects of amitriptyline, again, as I said, it depends on the dose. It depends on, I guess, the duration as well. I certainly use it at a much smaller dose, so I haven't really seen much of weight gain with the patients that I'd started on amitriptyline. But again, my experience is probably more limited compared to a family physician who may have used this at a higher dose. So in my experience, I haven't had much weight gain in my patients. Are there any recommendation to Ozempic? Yeah, so these basically the GLP-1 agonists, so the way they work, these medications such as Ozempic, they essentially decrease the appetite by stimulating a hormone called incretin, and it gives you satiety, so you feel full, but it also slows down your entire GI tract, so it can actually exacerbate constipation. One of the side effects of Ozempic is actually diarrhea, but it's a completely different mechanism. It really slows down the colonic transit, and it can actually increase nausea, vomiting, abdominal pain. So we do tend to see a lot of GI side effects with it. But unfortunately, it becomes a bit of a challenge to treat patients with the side effects of Ozempic because a lot of times patients are not diabetic and then taking these medications for weight issues. So you may need to go on one of these medications I mentioned, depending on the severity of the symptoms that you experience. But we do certainly see gastrointestinal-related side effects with medications like Ozempic. Yes, rosuvastatin can definitely cause constipation. Remember, any medications you take can have side effects. So when I take a history from a patient who known to have constipation, all of a sudden they have worsening symptoms. Of course, those are the things that I also take into account. Is there any new medication that was started? And for sure, medications can contribute to that. What about 5-ASA? So 5-ASA or mesalamine are a group of medications that are meant to be used to treat ulcerative colitis. We don't use it in patients with irritable bowel syndrome, at least not in the guidelines. Talked about SIBO. Pinivarium is diacetyl, so I did mention that as an antispasmodic. It is a reasonable drug that you could consider using if there's a lot of cramps or abdominal spasm, bowel spasm. So that's an option that it's a prescription medication you could get from your family physician. Maybe I'll just take one more question. Someone asked about sort of the changes in the bowel habit around sort of perimenopausal age. That could certainly be a contributing factor for sure. The hormonal changes can definitely affect the GI symptoms, but certainly if this is an acute change, particularly as I said, with the symptoms around age 50, you want to make sure that there's nothing else going on. So definitely talk to your doctor. I tried to answer as many questions as I could. Sorry.
Thank you so much. I've learned a ton. We'll try and get that the guidelines uploaded to our website under the medication handouts. Would that be okay?
Yeah, absolutely.
And then are you okay with sharing the slides?
Yeah, no problem.
Perfect. So everybody will share the slides. We'll invite Dr. Moosavi back in the near future. And thank you again so much. Have a great weekend, everybody.
Thank you.